Dr. Adams and other witnesses, welcome. Dr. Adams, we're really proud of you in the state of Indiana, and we think you're doing the country proud in your current capacity. I was really glad to see you highlight the important work of Belden Industries in Richmond, Indiana, in your testimony. They're really making a difference as well. Dr. Adams, Dr. Todd Graham, a South Bend physician, with over 3 decades of service, was senselessly killed on July 26, 2017, for refusing to prescribe an opioid to a patient. Tragic. And in his memory, I worked with then Senator Donnelly to pass a provision in the SUPPORT Act that aims to reduce the overprescribing of opioids by examining ways to expand the use of non-opioid alternatives within the Medicare program. How is HHS working on increasing the utilization of these non-opioid pain management approaches?
Well, I got to tell you, this is a major point of emphasis for us. It's part of our 5-point strategy, better research on pain and addiction, and it can't happen fast enough. What folks don't realize is back 20, 25 years ago when I was in medical school and they told me pain was the 5th vital sign, it came from a good place. We did and still do have an epidemic of untreated and undertreated pain in this country. We threw opioids at the problem foolishly. Now we're pulling them back, and we've got a significant decrease in opioid prescribing. But what I say to folks is that if we aren't also measuring what we're substituting in its place to treat pain, then folks are going to continue to self-medicate. They're going to continue to be angry when they don't get their pain treated, and we're going to continue to chase our tails and play whack-a-mole. So the NIH HEAL initiative awarded $945 million in the form of grants, contracts, and cooperative agreements across 41 states to increase research and practices in terms of pain and addiction. And we've also gone around the country and lifted up these different payment mechanisms. CMS has done a lot to make sure we're paying for the right things. And I've actually worked with businesses because we put a lot on CMS, that we've got to remember that the other gorilla in the room are the employer-based insurers, and we need to make sure they're paying for alternatives and not being the first drug dealer. Many of them will pay for 60 Vicodin, but won't pay for one of those alternatives for their covered lives.
Well, thank you. I think that's really important, and there's a lot of emphasis on it, appropriately so, on increasing access to treatment. We also need, and I know you agree with this, to make sure that people are in treatment services that are actually working. And this is something I place great emphasis on during the HELP committee hearings pertaining to the opioid crisis last Congress. In your testimony, Dr. Adams, you say we've amassed a mass of evidence on effective prevention, early intervention, treatment, and recovery strategies. Can you elaborate on the evidence you're referring to, especially in terms of treatment? Because as I travel around the great state of Indiana and talk to different service providers, doctors, and others, I have to say there's heterogeneity. There's oftentimes varying perspectives on what works and what doesn't work.
Well, you mentioned a couple things there, and I'll work backwards. I highlighted Grayston Bakeries and Belden because we need to make sure that when someone is done with treatment, they can be reintegrated back into society. Stigma is killing more people than overdoses, and it causes people to relapse when they can't find a job, when they can't be reintegrated into society. So work is a very important part of this, both training and then taking a look at the scarlet letter we attach to people when they come out of a treatment center that prevents them from getting a job. As far as substance use disorder treatment centers, you're right, there's way too much heterogeneity, and I would actually turn it over to Mr. Mendel to highlight some of the key aspects of what we should look for in a treatment center.
Absolutely. In a treatment center, we've identified, actually, we've talked 7 principles that every treatment program should have. Number 1, a full and complete assessment, not just of addiction issues, but also mental health issues and any physical issues. It needs to be complete with all 3, with an evidence-based instrument that's proven to be reliable and valid, delivered by someone who has the credentials to ask the questions in the right way and understand it. Number 2, once you have that assessment, to be continually reassessed and your care adjusted. If I have chest pains today, I go into the hospital. They will not tell me based on the first 15 minutes of questions, here's what your treatment's going to look like for the next 28 days. They will tell me what my treatment's going to look like for the next 2 days or 1 day, and then they'll test me again and readjust it all along the way. Many treatment programs don't do that, so continue reassessed and care adjusted. Number 3, evidence to evidence-based medications, not just for opioids, but also for alcohol. There are evidence-based medications. Number 4, access to behavioral therapies that are evidence-based. There's only 7 that were in the Surgeon General's report, both originally in 2016 and highlighted in the spotlight, that have randomly controlled trials tested and proven to work. They have to have those. I can go on, but it's all on our website, but they exist, and they're easily measured.
So that's encouraging, and I'd also note it as it takes 17 years on average for evidence to actually reach the field. That's going to be unacceptable, so I would welcome a future dialogue about things we might be able to do at the federal level to compress that time frame, sir.
I'll highlight again, use your bully pulpits to share the Surgeon General Spotlight on Opioids, which list the steps, the criteria to look for in evaluating a treatment center that we worked with Shatterproof to help develop, but we need you all to help share that.
Senator